Great. And so I guess like full disclosure, just to give a little background to myself, and I'm not claiming to be an expert in COVID-19 or immunology, but my background is I've been in vitro diagnostics, which is basically like blood testing and testing for different various diseases throughout my career. But I've been involved in over 30 years in this. My current, and actually I am a Stanford alum. I did my master's at Stanford in cancer biology and bioengineering. And so currently being a part of Thermo Fisher, I've been there now about 5 years. I'm on their task force for COVID-19. So I'm pretty much up to date on various testing strategies, and we have a lot of information coming to us regarding how it's affecting the population, where things are going, and then also, where testing in the future is going, because this has really affected us as a global economy and how we do business in different areas. And so I hope to give you a little bit of insight on, maybe where the trends are going, and also, how to protect yourself in the future. So I look forward to your questions.
Brilliant. Thank you so much for taking out the time again. So I'm gonna start with a little background on your career and how you got here, and then of course before segueing ourselves into COVID, a little bit more about what do you think about diseases like COVID, which is the novel coronavirus strain.
Sure.
So would you like to proceed with a little bit more about yourself in terms of, how long have you been living in Bay Area? What's your, interests,
Sure.
other things, so that we make it more personable.
Oh, for sure. Okay. So so starting my undergraduate down in UC San Diego in bioengineering. Actually, I was planning on going to medical school. So my parents were living here in the Bay Area in Cupertino. And so after college, I came up here, and while I was studying for medical school exams and seeing where I wanted to apply, I took a job at Stanford in the medical center doing research specifically in prostate cancer. And I guess I kind of saw the physicians' lives, and I was like, not really knowing if I can make that kind of commitment. And I really enjoyed the research. And so I stayed at Stanford working in the medical center, but then pursued a PhD. And then also during that path, I was working a lot with industry. And I guess I was kind of like pulled away from my PhD program early because I don't know, I guess I liked making products or making kind of like an impact in the research. Been in the Bay Area since I moved back from San Diego. I've been here, lived in San Francisco about like 15 years, and now like I'm in the peninsula, right in Redwood City, right near Stanford. And like I said, I've been pretty much in the in vitro diagnostics world for most of my career. I worked in autoimmune diseases. I worked in diabetes testing and different variants and thalassemias. And now more recently with Thermo Fisher, where we do toxicology and drug testing, as well as we help laboratories stay under control by providing them materials to ensure that all their tests are working properly. And now, more recently with COVID, there's been a real push to make sure that we have both rapid diagnostics and molecular testing, and I'll go into a little bit about what the differences are in the tests. But yeah, I consider San Francisco my home. Being there the longest time, probably lived in a number of different places in the city. And then as we had children, kind of moved out of the city into the suburbs here. So
like everyone else.
Yeah.
Absolutely. The moment you start the family, then you kind of move towards the Bay Area. So
Yeah.
tell us more about COVID. What are the different tests, and why are so many tests in the market? We just don't get the need for FDA recommending so many tests, and then the results vary, and then there's no reliability as well. I mean, that's what we know, but from an expert's perspective, what is going on?
Sure. So, yeah, let me see if this, we'll probably start with maybe some of the basics. So can you see my slide okay?
Yeah, we get.
Okay. So, so maybe I'll just take you first through, what happens after you get infected with the virus, because this kind of goes into some of the different tests you'll hear about. You'll hear antigen tests or molecular tests versus antibody tests. And I think first you need to understand what happens in your body after you get infected, let's say with a virus. So if you look, the first thing, once the virus enters the body and they're seeing that, because it's an airborne virus, it's kind of first habitating in your nasal passages. And so, inside your nasal passages, that's where the virus is first kind of growing up and using that media, and where your viral load is then significantly increasing. Okay, so with that part, that's where you hear about the antigen tests. So when your first kind of exposure to the virus, your viral load will significantly increase as the virus is able to live in your body. Now, what also happens is the virus starts, so you see here in this chart, your viral load first starts off in the first 7 to 10 days where it's detected in your nasal cavity. But then after some time, it then starts going down deeper into your lungs. And that's where, for some patients, will really start causing havoc and more of the symptoms and the, let's say, fevers and other complications. So that's what we see. So first thing, virus comes in, then as it gets into the lungs and starts more proliferating into the lung cells, that's when your body first starts having an antibody response to it. And antibodies, so your body's first reaction is what are called IgM antibodies. So these are kind of non-specific inflammatory response to a foreign pathogen to the body. Then as the immune system starts, let's say, understanding what the virus or the foreign body is, it makes much more specific antibodies called IgG antibodies. And these are very effective in targeting specific foreign matter and having a response to be able to remove the virus from the body. So for the testing standpoint, that's why people are saying within the first 7 days to go get the nasal swab to understand that'll tell you if you do have the virus in your body. And then there are also tests later that are more in the immune response to the virus. And so these are long-term protecting antibodies. So, and this is also the means for how vaccines work, right? So what a vaccine is basically giving you a deactivated form of the virus so that your body can generate these IgG antibodies against it. So when it sees that virus again, it's able to skip that initial phase and go to a much quicker response in removing the virus, okay? So when you hear about the different tests, there's the antigen test for early phase, and then the antibody test for, let's say, a longer phase, and they can last, protection can last years, right? Now, the difference also with the antibody test is if you did test somebody for an antibody, you can't really tell if it's a new infection or they got previously infected, right? So that's why, right now we're concentrating very heavily more on the antigen test because we want to stop the spread of active infected patients, right? And this is where you might also have heard terms of herd immunity, right? Where basically, that's also another consideration of the COVID virus is a lot of people are asymptomatic and just carriers of the antibody. So there might be a lot more people out there that have been previously infected, but actually have that protection because they've been, previously infected. They might have thought it was just a regular cold and not worried about COVID. And now, here's the later term for them.
So two questions. One, if you've already had COVID before, can you not get it again? And secondly, these guys who have these people who have the antibodies and they are they're asymptomatic, aren't they the bigger carriers?
Mm-hmm. Yeah, so the asymptomatic people are definitely still carriers. So that's what actually complicates this. Actually, let me see. I think I would have something there. Oops. Yeah, so telling a good story. So actually, back in 2003, right, we had a previous SARS type of outbreak, right? But if you look at the numbers, it's a lot less. The mortality rate was very high, though, 10%. And actually, for the elderly people, it was somewhere around 50% mortality rate. The reason, one of the main differences between the SARS 2003 and the current one is that there was much more heavy symptoms of these people, and a lot more people, even though the mortality rate was low, there was a lot less asymptomatic people. So it was much easier to contain those people and not spread because of the asymptomatic aspect of it. Now with SARS, with the COVID-2, it's a much higher prevalence because there's a lot more people walking around with it that don't know they're infected because they have no symptoms. And so that's kind of like one of the main reasons of the differences. And if you also look at just like other, history of other incidences of viruses, like we had H1N1, that one affected a lot more people and it was a lot more widespread, again, because there was a lot more people that were asymptomatic, or the symptoms were much more milder in a larger part of the population. And the mortality rate was much lower. It was lower than actually what the seasonal flu is, right? So like, if you look at, and so I think when everything started, there was a lot of discussions, I think, about people about like, hey, it's almost the common flu, right? But the problem is this asymptomatic piece, and that's what really turned it into a pandemic, because it's much harder to contain if everyone just doesn't have precautionary steps, because you don't know if you're a carrier or
not. So herd immunity will not work.
Well, so there's no, I didn't say that. So herd immunity. So that goes into like, so if we look back at like what the response level is. So there's a lot of people, I feel, that are walking around because we're not testing everyone, because not everyone, feels flu-like symptoms or, during this time and going and asking for a test. If we did a much larger screening of everyone, I feel like you'd have a lot higher incidence of people that actually had been previously infected, right? It's just that we're not testing everyone. The people now, if you had been previously exposed to the virus, now that's where the complications come in. You still, like, even with the flu virus, for the flu vaccine, for example, everybody, or a lot of people get vaccinated for the flu. It doesn't mean you don't get sick. It just means that the amount of time that you are sick, if you do get the flu, is much more reduced. And that is because your body knows how to attack it much quicker. So before it can wreak havoc in your body and kill cells or cause that next, damage to your body, your immune response is much quicker, able to fight off those pathogens.
But then this virus has crazy number of strains. And then how does, I mean, obviously that wouldn't work for the concept of herd immunity, but also can you get different strains of the virus simultaneously? I mean, or consecutively? How does that work? And
Yeah,
then
I
of course,
think
the tests around it. How do you evolve the test? How do you know it's a strain of this virus and not something else?
gotcha. Yeah, exactly. And that's where we're, I think a lot of the testing is starting to go is like when people have flu-like symptoms is to do, let's say, panel testings to see if you actually have like flu A or flu B versus COVID. Um, the and and that's where I think things are still kind of dicey, let's say, because we don't have the data back on the recurrence part. So how well are you protected from a previous infection, as well as what the efficacy of the vaccines will be? I mean, right now there's a number of different paths that people are taking on how to create the proper vaccine, and until that data comes out and see what the efficacy is, I think it's still an unknown piece for us.
So Tony, how much does the virus mutate, and what is the mutagenicity of the virus?
Yes. So when you look at, so basically, everything in the world is mutating, right? So viruses, in one sense, that they're also mutating many different times over. So if you look at like what a virus looks like, for the SARS, it has a specific spike antigen. So this one is actually the thing that's making the virus enter into the body, right? So this is let's say a binding domain of the virus that helps it enter into especially targeting lung type tissue cells, right? And so you have to think of mutations are happening all the time. For the viruses, this is how they proliferate and live. This is where you can say, like, evolution, we've caused some of these diseases to become worse, right? Because they're trying to live. And so when we come out with a vaccine and we can fight against it, it's going to mutate and then, form into something else so that it can live. It wants to, it's part of evolution, right? The problem is, or the complications are, is it all depends on the type of mutations. Some mutations happen and then the virus just can't live anymore, or it can't enter. Some of it will make it more effective, in the sense from SARS, the original one in 2003 to now, it's actually less damaging, right? But it's more prolific and is able to live longer in different situations because there are asymptomatic cases. So that's the real trick with both the vaccine development and immunity, as well as in diagnostics, to target and find areas that you're testing for that will be conserved as the virus mutates. So you're looking for areas that are like key to the virus living or making it specific to the specific virus, that we have targets in the assays or in the vaccines that ensure your body will still see this virus in its form, right? Now there's always still the possibility that a mutation happens that actually affects either both the diagnostics or the vaccine, and that's where in a sense we'll be living with these types of viral attacks for the rest of our lives, because that's just the nature of viruses changing and mutating to avoid your immune system to be able to recognize and deal with them.
So, when we started looking at how it badly affected our country, the word on the street was that the virus in New York is different from the virus on the West Coast, because the virus in New York came from Europe, whereas West Coast, it came from China. Mm-hmm. How do you make that determination, number one? Number two, what was the difference?
Yeah. So I'm not 100% clear on, what the difference and in, how it affects people, but from the detection standpoint, as we and part of developing the diagnostic, we will take the viruses and then sequence them and understand the exact formulation from an amino acid standpoint to fully characterize what the virus looks like. And so that's how we identify where different mutations come from. And this is where things get like really complicated that I probably, can't answer to the fullest, is that, there's also, so some mutations may affect different people different ways. They have genetic dispositions for the virus to be able to attack different cells different ways. So it's a very, I guess you could say, complicated thing on how, doing risk stratification of the populations for, who is more susceptible in different forms of different viral mutations.
So the rumor on the street was that, we didn't believe it, but a lot of conspiracy theories around China manufacturing a biological weapon in Wuhan and sending it out for the world to suffer while they are happy and, back to economic recovery. Is that true? Is that even possible?
Well, sure, it's possible. And it's also possible to, let's say, not genetic, let's say, make it in a laboratory, but also see, like, while people are doing virology studies, they might be infecting different hosts, so we hear like either bats or rats or different animals, and there might be, let's say, biological studies being done in laboratories. I mean, there are sometimes, where that infection might leak out of a laboratory. From biological warfare, I mean, it's always a concern. I think initially when SARS-CoV-2 came out, I think people were looking at like how like it was a perfect storm of the virus to have all these different components, all part of the same viral structure. Their first initial reaction was that maybe this was a constructed, but I think now I think there's plenty of evidence through a number of different journals that say this wasn't like a manufactured virus. This was definitely something that came out of nature, but when we say nature, it could still be where, a virus was inserted into an animal to try and elicit what the response was, or even doing some research to see how and what cells of it affected. And then that leads to, a different construct that could potentially get out. So yeah, I guess the jury's still out if somebody was doing an experiment in a lab and, cause this type of mutation to happen in an animal, but it definitely, the data shows that it was still a naturally occurring instance here.
So no proof for those conspiracy theories?
I've seen a lot to show that it's not, yes.
Okay, perfect. So we settled that.
But it still doesn't mean that there isn't
a
fear of people using biologics and, and causing such.
But tell me, Tony, it hasn't been done successfully so far, right?
That is correct. It's a very difficult
biological weapon out there that has been created and successfully deployed so far.
Correct.
There hasn't been, right? So we said the fact that this might not possibly be a biological weapon, but if there's a chance that this is, we are looking at a disastrous world. Anything can happen then.
Yes.
So what are the possibilities that is a future for us and our children?
Well, I really hope not, but yeah, like anything, I think as this comes about, it's all about science keeping up with these kinds of problems that we have to deal with, right? So And it's also, you know, we cause some of these problems even ourselves, right? Because we are coming out with vaccines. The viruses and diseases are getting stronger and stronger over evolution here. Yeah, I really hope it doesn't go that way, but there's some crazy people out there.
So Tony, what can we learn from this pandemic if something similar happens in the future?
Right. So yeah, so I think there's a lessons learned through the world, you know, throughout the world, and it affects many different things, you know. So you know, things like the healthcare systems, the triage systems, right? I think you know, how hospitals are able to gear up towards these kinds of events. There's also, you know, I think what was probably one of the harder things too is like just the whole supply chain management, you know, actually across multiple parts of the industry, right? How do we get masks quick enough? How do you know, make certain things available, you know, like the whole mask thing, right? Originally they were saying don't wear masks. Well, you know, it's probably, they were saying because you're taking the masks away from healthcare people, you know, and the people that really need it on the front lines because there aren't enough, you know. But if the supply chain was available to be able to ramp up to be able to handle certain situations like this, I think people would be, you know, things would be a lot better off. So I think, you know, I think people are still learning now that the whole quarantining is, you know, is the most effective means, and protecting yourself with masks and that. As we see different countries and different areas start, you know, lessening the amount of social distancing and allowing different events to happen, that we see spikes. So these, you know, it's still out there. It's not contained. And in one sense, all you need is still one infected a person to, you know, rapidly, exponentially affect many different people. So you know, I think those areas that are, you know, being very diligent. I mean, I could even say at my own work where we have like probably 500 people that have never really left throughout the pandemic. You know, because of all the safety measures that we've had in place, we haven't had one case of person on, you know, on site spreading the disease. So so the precautions that we have in place, and like kind of like listening to them and being diligent about it until a vaccine is available, you know, is really our only path forward.
So now we're talking about vaccine, and I believe most of America, a lot of America, as anti-vaxxers. How does that affect us? Will there be no end to this, because half of America will not want to vaccinate? I think 4 out of 10 will not vaccinate themselves.
Right. Well, it goes to you know, what we were talking about earlier. So those that are going to be vaccinated, right? You know, they will have less symptoms or less possibility of having, let's say, larger health issues. But the virus itself is still going to continue to live. It's still going to continue to propagate and be spread. So either, you know, I hate to say it in this way, it's like either you're going to get infected and be asymptomatic, or you're going to get affected and possibly die. And so I think it's going to be like a or you get natural immunity where you've been exposed before and now you're able to fight it off. But it's basically something that we're going to have to live with for the years to come. You know, it's even post-vaccination, the virus will still be out there, just like other flu viruses.